We have all of our presenters?
Yes. Yep.
Okay. All right. Well, good evening, everyone. Glad to have you at our September training, which is sponsored by South Dakota EMS Association District 4 and also Northeast South Dakota AHEC. And it is brought to you by the South Dakota Community Foundation. So we are very, very happy to have you all on board. We have a great kind of a roundtable set up for you tonight. A couple of quick announcements before we get into it is those of you who are needing ALS hours for this, please send me an email. And Michaela, could you put my Outlook email in the chat box, please?
Yes. Yep.
Send me an email. Let me know that you need ALS hours, and we're going to get those hopefully out to everybody by about the 15th of October. I know we've had some issues getting the last two out to you, but hopefully we have those issues resolved. Have been working with the osteopathic folks to get these hours approved ahead of time, and hopefully we've fixed our issues. So for those of you that are needing the ALS, make sure you're sending me those emails or just drop it in the chat box that you need ALS hours. That's fine. Happy to see a few new people on that we haven't seen before. Great to have you on board. Also, if you're planning to attend the South Dakota EMS Association conference, that is coming up at the end of October. So we'll get signed up for that. That is in Pierre, South Dakota. And yeah, get signed up for that so you can take part in all that great training. The folks in Pierre have been working hard in those two districts that have it this year. Been working hard to bring some good folks in, and Northeast South Dakota AHEC is actually helping do a lot of the virtual side of it. So if you can't attend in person, please sign up for the virtual option so you're able to get those credit hours. And yep, I see that, Chuck. We didn't get the last 2 months done yet. Like I said, I'm working with the osteopathic folks to try to get the whole year approved. Been kind of an uphill battle, but we're getting there. So without further ado, I'm going to turn it over to our three panelists tonight. And Michaela, do you have anything, I guess, before I do that?
Nope, it's good.
Okay, so just like any other training that we've had, if you have any questions that you don't necessarily maybe want to ask in person, drop them in the chat box and we will ask those to our panelists. Our panelists are going to be talking to us about a couple of different pediatric topics, and I'm just going to kind of turn it over to them. So I don't know, Carola, do you want to start and introduce yourself, and then we'll go to Dr. Anderson and our other presenter as well?
Sure, absolutely. Hi, I'm Carola Lauk. I am with South Dakota EMS for Children. I'm super happy to be here. Actually, I'm super happy to be home. Jamie Bartell and I just spent the last 3 days. I actually got home a half an hour ago. The last 3 days working on our pediatric readiness project, and handed out several pediatric safe transport kits with Brazil tapes and things. So super excited to be here tonight, and I thank you and look forward to the rest of the evening.
Dr. Sue, I see you up there. You want to introduce yourself?
Yes, hi. A pleasure to be here, and thanks for the invitation. My name is Benson. I'm a pediatric critical care physician out of Sanford Health, also a professor of pediatrics out of the School of Medicine. Excited to have the conversation. Look forward to hearing all the questions and seeing what we could do together.
And Dr. Anderson.
Yep, I can't get my video to work, but I'll say hi to everybody. Some of you are also on video and have nice pictures, and I wish I could put a nice background, but I can't. I work in Falkton. It's a rural critical access hospital in central South Dakota. And I guess I'm participating in this because we are trying to get some people in our area interested in taking EMT and possibly paramedic classes as well. But we work out here kind of in the middle of nowhere, and I hope the perspective that I bring to this discussion is what you actually do in the middle of nowhere where you don't have any resources. So.
All right, great to have all three of you on board. Michaela, how do we kind of want to do this? Do we have some questions to start with, or what did you think? How do we want to start this?
Yeah, so I guess our first topic kind of is pediatric allergic reactions. So if you guys want to talk about maybe some of your highlights that might go under that topic, if that works, or Kyle, if you want to ask some questions.
Yeah, I think that's a good way to start it. I think we'll kind of just go around the horn if that works. Benson, if you would like to start on that one, kind of talk about, you're right in the center of my screen, so you got the first one.
Yeah, I feel like I should move my picture somehow, but I don't know if I have that ability. So pediatric allergic reactions. Obviously in the ICU, I think of anaphylaxis as kind of the big, bad, and ugly that you all may see out in the field. So the first thing that comes to mind is recognition. So how do you recognize it? What are you looking for? What are you worried about? And then what do you do to immediately treat? Recognition is sometimes looking at kind of the classic presentation, whether it's angioedema, tongue swelling, difficulty breathing, hemodynamic instability. Sometimes it comes with GI complaints. Anytime it gets into kind of that cardiopulmonary aspect of concern, my suggestion is you could always use EPI-IM. So if I were to say that there is a strong takeaway from this first little part about anaphylaxis, I would say an EpiPen is always going to be your friend. Dose based on weight, and it's pretty straightforward as to the dosing. And you can't really be wrong by giving somebody IM Epi. So never be afraid if you are worried that there is a consideration of anaphylaxis to go ahead and give the Epi. The worst thing is that they don't have anaphylaxis and they're going to be jacked up a little bit.
Great, thank you very much. Corolla, you're next on my list. If you'd like to have some input on pediatric allergic reactions.
I'd love to have some input on this. We actually had some delightful conversations with some folks out west. Dr. Benson brings a valuable point. So we need to be very familiar with our EpiPens. Probably time to dig your EpiPen out if you haven't had it out for a while, folks. And when we look at what our weight is, so typically what we use out in the field is that EpiPen Junior, and then we use an EpiPen Adult. 33 to 66 pounds, that's going to be your 0.5 or 0.15 milligrams is what you're going to use. And then your 66 pounds and above is going to be your adult dosing that you're going to use. Dr. Benson and Dr. Anderson, if you would weigh in on this. So part of our conversation last night is the new 2019 Broslo tape is out, just to let you guys kind of know. When you have a child that measures in the green zone, so once we get into that green zone, your kid is basically about 66 pounds. So here's that dilemma that we may have. Do we have a small 66-pound child that weighs into the green? Because remember, when we use that Broslo tape, it's estimates. So do we use EpiPen Junior or do we use an EpiPen Adult? Dr. Benson or Dr. Anderson, thoughts on that?
Use the adult.
Use the adult.
Yeah, so my perspective is more is not going to be hurtful. And if anything, again, especially if you're on the border, the adult dose, I would prefer that you all use just to ensure that you have that coverage.
Okay, so then a little bit more to take that into it. When you have the opportunity to spend some time one-on-one with folks within their ambulance services, you learn a lot about folks. And this particular service that we were with last night was very open. A lot of you know that my theory is if you're not laughing, you're not learning. And in the learning process of this, we had a gentleman that was getting ready to give Epi. And as he was getting ready to give Epi, he used the auto injector and he injected it into his thumb. So then he ended up, this was for an adult patient, but then what he ended up having to do is they used the pediatric dose on the adult. I've had it where one of my firefighters injected 2 doses into his thumb. So be familiar with your EpiPens, treat them like a loaded gun, if you will, and let's not be loading Epi into our thumbs. Oxygen, I think, O2 is super, super important to make sure that we have that on board. Distance, when we look at distance, Dr. Anderson brings up a really good point. When we're out in the middle of nowhere, where is our closest hospital facility? Do you have enough epi on board to get you from point A to point B? And the other aspect of that is who are you going to call for backup if you're a BLS unit?
Dr. Anderson, would you like to weigh
Sure.
in on the topic?
Yep. So, I guess we've been in a situation where we have had a child go into anaphylactic shock while they were hunting. They were exposed to something out in the field that they were allergic to, and they started going into anaphylaxis. And luckily, the person that they were hunting with actually was an RN, and she miraculously had a little kit with her, and she had an EpiPen and she had like an albuterol inhaler. Usually an ambulance in our area would carry an EpiPen. We don't really carry albuterol inhalers because we're a BLS service, but I do believe most ACLS services do. But she was able to get this child in a distance of 20 miles very, very quickly. And by the time they got here, they'd actually improved their symptoms and we didn't have to do a whole lot extra. But if you're going to throw them on the back of the ambulance, first of all, you need to make sure that you have an adult probably to go with them. To throw some oxygen on, do the EpiPen. We do not carry a junior EpiPen. We just use the adult, but really I'd rather have you give it and then get them here and then have us take over from there. Sometimes it can be scary. My experience is those EpiPens do last for about probably 10 to 20 minutes, and that's usually enough time to get you to where you need to.
Awesome, thank you. Okay, so let's open it up for questions on pediatric allergic reactions before we move on to our next topic. We have any questions out there for our presenters? Thank you guys very much for the opening remarks. Those are great.
It looks like there's a couple in the chat. So what do you do if if the patient is less than 33 kg?
So you could do weight-based dosing. So less than 10 per kilo, you do 0.01. When you think about that, it starts kind of messing with you, kind of drawing things up. So I think plus minus, especially out in the field, out in an emergency type of a situation. 25 kilos is kind of that breaking point, if you will. And I always have to do the math to convert it to pounds. 55 pounds is kind of that line in the sand. So less than that, use junior. Greater than that, just use the regular EpiPen. And so that's kind of my distinction. Very specifically, less than 10 kilos, you're supposed to dose it by weight. Greater than 50 kilos, you could dose it by weight as well. But again, it's one of those instances where I prefer you start get things going as opposed to try to figure out the exact precise dose.
Great.
Yeah, I would agree with that too. I think that's a good point, is I really don't care how much you give, just as long as you give it, and try to give it to the child and not yourself, although that happens. So, and we actually know that in a rural area, and we prescribe it pretty liberally. Anybody that has a potential history of anaphylaxis gets a prescription to take home with them. Most of them can fill it. Some people can't afford it. There are some pretty good programs that'll allow patients to get their EpiPens for a reduced cost. They used to be almost, I think, $800 at one point. And so you do have to keep that in mind too, but use it.
What's our thought about if you would a Benadryl, diphenhydramine, BLS units and albuterol?
We have.
Or I'm sorry, diphenhydramine.
We have Benadryl. I don't remember if we have it on the rig. We have oxygen on the rig. We have what the state of South Dakota allows BLS units to have on the rig, and I don't have that in front of me, but we might have Benadryl. We have oxygen. We have an albuterol inhaler, but technically you are supposed to have them use their own inhaler, but we have one on the rig just because I don't feel comfortable not.
So what I would say about adjunct therapy, so if you're having anaphylaxis, it's epi, followed by epi. And the adjunct therapy such as diphenhydramine, the H2 blockers, famotidine, all those things are additive to the situation, even steroids. And you're thinking about other pathways to prevent the anaphylaxis or that persistence of anaphylaxis. Now, having said all that, those are great. Get oxygen, get albuterol, get steroids, get diphenhydramine, Benadryl, famotidine, Pepcid. All those are fine, but your mainstay, your first thing should always be epi. And I see that there's somebody who wrote, what can you do with no epi? So I'm going to presume that you all carry epinephrine in the IV dose format. So you end up drawing that up. And I have kind of this cheat sheet in front of me. So epinephrine 1 milligram per ml. So for kids, 0.15 mLs. For the regular EpiPen type, 0.3 mLs. So you can always just draw up your epi, which I presume you all have, instead of an EpiPen, and do an IM injection as well.
So our ALS units, our ALS services would have that. But we do have a couple, and I'm going through the names, and I've noticed a few of them. We do have a couple of services who are more of a first responder unit with EMRs, maybe a few EMTs that are going to be going to the scene first, and they may not have an EpiPen, and they might have no epi at all. So I guess as far as what those services can do, I would probably maybe start the conversation and say that they need to recognize that if it comes in as a anaphylactic reaction, that they need to get ALS coming. And if we are even, I mean, what would you guys think about if we're 20, 30 miles away from our ALS unit and we have no epi? Is this something to get air support coming to? I mean, would that be something that would be acceptable? I guess is maybe the question that I'm gonna, back a question up with.
I'll take a first swipe at this, but I really want Dr. Anderson to weigh in. But I will take your question and kind of tie it into the next one about children presenting with rash, and I'll address that here shortly as well. But I think the first thing to say is, what is the severity of illness that we're dealing with? Is this the beginning of allergic reaction? Hey, there's a little bit of rash, but the child is otherwise looking okay. Then the heat goes down a little bit and you say, I have time to drive to where I need to get to, even if I don't have epi. If you have a child who's now coughing, looking uncomfortable, air hunger, swelling, then I would say maybe somebody with epinephrine needs to get to that child sooner than later. Now, I say that in the nice comfort of living in Sioux Falls with a lot of resources around me. So I'll stop talking and let Dr. Anderson and others weigh in.
Well, I know that Corolla too, you've been doing a really good job of getting the ambulance services up to date with pediatrics. And I'm kind of glad that we're having this talk, because really in the past, we haven't done a lot of things with pediatrics. If you truly don't have epi and you need to get it there fast, in our setting, sometimes we have sent people out with one, like a nurse. We always send a licensed provider that's used it before, that's capable of using it. We're not always able to do care flight, but a lot of times we can send somebody out to get to the child a little bit sooner. We've done intercepts before with BLS ambulances versus ACLS ambulances. That doesn't work as well as care flight, but sometimes you have to do that. I see a question too, that can you use an expired EpiPen? Absolutely, you can use any EpiPen that you have access to.
As long as it doesn't look like pancake syrup. Just throwing that in there. So I'll weigh in with Dr. Anderson and both Dr. Benson. One of the things that EMS for Children is attempting to do is we're looking at those non-transport services. So those fire rescue services, and we're seeing more and more services. So our EMS agencies, they're having a tough time, and they're having a tough time with the number of folks that are even able to respond to a call. So again, our goal is to get Braslo tapes out there. What we're doing is we're putting the 2019 Braslo tapes in the hands of licensed ambulance services, BLS and ALS services. And then we're recycling those 2017 Braslo tapes, and we're going to go out and we're going to train those non-transport fire rescue services. We're throwing emergency managers in there. We're going to throw law enforcement in there as our pediatric champions. And our whole goal is to teach them how to properly use a Braslo tape. Using that Braslo tape, and again, I'm going back to the Braslo tape, if that team has the ability to at least get a measurement, that gives Dr. Anderson, it gives Dr. Benson, it gives Life Flight, any of the aeromedical or ALS units. It gives them a little bit of a heads up on what you have and where that child is in that weight range or in the color range, so that they can be prepared ahead of time.
Yeah, I would so agree. I think being prepared is very important. But I agree with what Carla and Dr. Anderson mentioned. I want to circle back to what Donna asked about how concerned are you when children present with rash and hives? So the way I would think about that, this is about allergic reaction, but we kind of took it to that emergency of anaphylaxis. So there's obviously various stages or different types of allergy. So I would say that if a child presents with the rash and otherwise looks okay, that's when you use the Benadryl. That's when you use steroids, and you don't necessarily need the EpiPen. Usually when I think about EpiPen, I think more airway or cardiovascular compromise. So if somebody presents in the ER and they have a progressive rash, and now they're clearing their throat kind of funny, and maybe they're a little hypotensive, I would be more worried. If just the rash, I'd probably be a lot less worried and treat it like an allergic reaction where Benadryl will come into play.
Great, thank you. Do we have any other questions regarding allergic reactions? Well, thank you guys for weighing in on those. Michaela, what do we have for our next topic? I don't have it in front of me. I gave the topics to you, but I don't have it in front of me.
So we have pediatric cardiac emergencies.
All right, great. So maybe we will just kind of go around again like we started. That seemed to work really good. And by the way, this Zoom roundtable is totally new to me. I've moderated numerous panel discussions in person, and it's really just kind of came naturally. But virtually, it's a little bit different. So bear with us a little bit. But I appreciate our panelists kind of taking over and just running with it. So pediatric cardiac arrest, we will, let's start with Dr. Anderson, maybe with this one. If you kind of want to lay some groundwork, and we will go around our panel and kind of talk about it, and then we'll take questions again. So anybody who has questions, make sure and drop them in the chat box.
All right. From my standpoint, from pediatric cardiac emergencies, this usually isn't a complete surprise. I can think of a handful of the cases that we've had in our area. And a lot of times if a child has a problem with their heart, it's because of a known birth defect. You kind of know, and the family knows that that's something that the child is going to have to deal with. Other times you can have a child that's presenting with a really rapid heart rate, and they have some type of an undiagnosed rapid heart rate issue, like a Wolff-Parkinson-White or something like that. In my world, we don't have a lot of resources. And so our first responders and our EMS basically are just there to recognize how sick is the child. They can give us some information on the appearance of the child. How are they breathing? What do their skin color look like? What are we going to find when they hit the door? And in our ambulance, I think the only thing that I would expect our BLS responders to do would be to throw some oxygen on that child, get some vitals and get a sat. Usually we don't even have the luxury in a child of getting an accurate 12 lead EKG, not even in our clinic with our nurses that are around children quite often. But usually I think it's enough for our first responders to get them on oxygen and tell me what's going on with them. Just describe everything that you see so that we know how sick the kid is, so that we can get some extra help. And then we send them on to Dr. Shu or somebody else's what we end up doing. But
Great. Dr. Benson, you want to kind of take it from there?
This is a very, very broad topic, cardiac emergency. So I'll take a step back and kind of comment on a couple of things. And again, I speak from being in Sioux Falls at a children's hospital with a lot of specialists and a lot of resources around me, and I understand that the rural environment is going to be drastically different from that. So the first thing I would recommend is know who's in your community, know the kids that are in your community, know what they have. Like Dr. Anderson mentioned, it shouldn't be a surprise to you on some of the kids who they present in some way. Barring that, rely on the parents. They should know a lot of what's happening, especially if there's a congenital cardiac issue that the family's dealing with. So kind of know the reason, because kids present in cardiac arrest in one of, generally, speaking, two ways. One is a congenital version, their heart's already bad and they code from that. And the other is actually the more common reason. You show up at a scene and the parents have no idea why the child's arrested. And more often than not in pediatrics, it's going to be respiratory in nature. So in an otherwise healthy kiddo who has a cardiac arrest, it's generally because of a respiratory condition, more than a straight cardiac. The thing about kids' heart is that they're extraordinarily strong, and barring a congenital malformation or an arrhythmia, such as an SVT, it's more common to be respiratory. So I'll say one more thing, and then I'll kind of let the discussion kind of take where it goes. It's very, very important, and I feel like this is what I tell my residents, and I feel a little sheepish telling this group that, but it's very, very important to remain calm. I think a lot of times, even pediatric residents, when a child gets really sick and is on that cusp of death, people kind of lose that calmness that's so important in emergencies. And what I tell my residents is this: if you look on the PALS card, there's not that many steps. Okay, so as long as you stick to the PALS card and just work the algorithm, you're going to do the best job you can. Not to say that you always have a perfect outcome, but you will do the right things just by following the PALS card. And from that, I'll add in one last thing, which is if you ever see me run a code in the hospital, and I see there's a couple of flight nurses in here and they'll back me up on this, I pull my PALS card out. I've been doing this for 10 plus years in the ICU. When I run a code, I'm holding my PALS card. Because it's kind of a security blanket, and it reminds me that when I'm coding somebody, there's a period of time we're just doing chest compressions and waiting, and that's okay. And don't forget your pulse checks. Don't forget to keep an eye on the time. But I always have my PALS card, and just staying calm as much as you can.
Great. I think that's a really good point, because even though this group is in the field, I think that it's a low frequency event to have a really sick child that we're called to. There might be some services who are a little bit more active than others in that, but it's a very low frequency, high stress event. So I appreciate the reminding of staying calm and going through your steps, because at that point in time, letting training take over is really where we want to be. When we can run an adult arrest, no problem. But it seems like when we get those kiddos in there, we have that pucker factor a little bit. So I'll turn it over to Corolla. You want to talk a little bit on this?
Absolutely. I'll kind of come from the provider aspect of being rural frontier as well. Weighing in with Dr. Benson, most definitely remaining calm. Remember, you as basic life support providers, you save us as advanced life support providers. So those of us who are paramedics, you tend to bring us back down to a level where we need to be brought back down to. I love the way Dr. Benson refers to, you know, stay calm, and he follows his PALS card. For those of you that are practicing ALS, your PALS card, you may not have a PALS card. Your card is going to be your Brazo tape. But remember another thing that, again, and it sounds like I'm just going over and over and over with this Brazo tape. I'm sorry about that. The other thing to remember is that the way that I look at a pediatric cardiac arrest, for primary example, it is the algorithm is very much the same as an adult with smaller doses. So don't lose your mind when you're treating a pediatric. Remember that we're just using smaller doses, and that's where you have to have the right tools. And those right tools are a 1 cc incremented syringe for those who are practicing BLS or ALS, I'm sorry. Remember that your pediatric cardiac arrest, it can be birth all the way up to the age of 18. So the Lucas device is something that we can use. Know your Lucas device, know it very, very well. When we're pulling that plunger down and it's coming up onto the chest, if you can you literally, or can you use that as a device to take away a little bit less of the stress and use that device to do what you need. Dr. Anderson mentioned ensuring that we're putting a 4 leads on. Put your 4 leads on. I know some of those patches are really super big on a tiny little 2 or 3 year old. Put them on, at least get a rhythm, and describe what you have to the responders or to the hospital facility so that they can. I've had a number of cardiac arrests out in the field in the rural setting. I think it's super important, or for me, being rural and small communities, you do everything that you can for the child as well as the family. And that becomes about getting the family to a hospital facility where they can get the care that they need. And those cares start with support, and that support, religious support, and any of those things in case we do lose a child. And then we don't need, we need to not forget about our providers, because pediatric calls will knock us on our backside really very, very, very quickly.
Oh, great. We had a comment come in on the chat box. Thoughts on hands-only CPR on children or infants for lay people who don't have access to a barrier device? Is compressions-only CPR helpful when it tends to be a respiratory issue?
That's a tricky question. So I'll start by saying, so I'll give you an example. So let's say a child in the pediatric ICU has RSV or has bad pneumonia, and we're on this non-invasive positive pressure, let's say BiPAP or a CPAP, and then the kiddo arrests. And I come into the room knowing that we're doing CPR because not enough oxygen has gotten into the system, and the kiddo arrested. Continuing chest compression serves the purpose of buying me time, and that's it. Because if you have a respiratory arrest, what you're saying is that there's not enough oxygen in the body to get to the heart to make the heart beat okay. And in kids, that's a pretty dramatic loss of oxygen because the heart will beat through almost anything in kids. So if you just continue to press on the chest, you may be buying just a little bit more time. And what I always tell my residents is that you have to fix the problem that's causing what's happening. And the problem is air. You need to somehow get oxygen into the bloodstream. So my thoughts about hands-only CPR is that if that's all you have, then that's all you have. But if you feel that you could get any sort of oxygen into the system, I think that's very important. And again, I'm saying this within the context of these are the non-congenital hearts that are presenting. These are the ones that you think are respiratory. Hands-only CPR will only serve to buy you time and not fix the problem.
And in our world too, you can do hands-only CPR, but just don't forget to put the oxygen on, because if you don't have an airway or an airway adjunct, one of the things you can do is put the nasal cannula on and the non-rebreather on, and then they're getting a little bit of oxygen. I don't know whether it's by osmosis. I don't know what the correct term is, but it's at least something else. And emotions definitely do run high. And anyway, that's a tough question. And I did have another question that I wanted to discuss with Dr. Shu, since you were on, because I actually saw this in the South Dakota EMS handbook when I was kind of reviewing things, and I wanted to see what's correct. So when is it appropriate to stop CPR on a child in the field? Any thoughts on that?
I don't think there is a hard and fast rule about when to stop CPR. The ones who've worked with me in the ICU have seen us do several things. And for me, a lot of things weigh in. The time, the duration of the arrest, how long have you been doing epi and chest compression? Whether it's witness or unwitnessed, what does the child look like upon, when you're first evaluating? Those weigh into like the likelihood that somebody is going to return from that arrest. You notice that I didn't mention any time because a lot of the times when I'm running a code, what's in my back of my mind is that if I'm looking at a child thinking that there's almost no chance for survival, I may still continue to run a code to allow families to either get there, to say goodbye, to have that time at the end, and to what Carola said earlier, when we take care of kids, we're taking care of the family. And I have run codes longer than I know I should to allow the families to get to where they need to be to let go. I tell my residents sometimes that once we get to that stage of our medical care, what we're doing is we're providing the family, the loved ones, a memory that they'll live with forever. So what is that going to look like? Is it going to look like that we did it for 5 minutes and walked away? Is it going to look like that we did everything possible in their eyes before stopping? So Dr. Anderson, I hopefully dodge your question appropriately. But what I'm really saying is, it's up to you. You guys know if a child is going to survive. And I have never second guessed anybody in the field who stopped the code because you guys are the ones there. In the times that I've been called, I would say, if you feel that it's the right time, I would back you.
I think it's appropriate. The thing that the South Dakota EMS handbook actually says is that you should do your best to have both parents there. Even if they don't live together, you should do your best to have both parents there so that they can have closure.
Can I go back to Nathan's question real quick? So his thoughts are, again, hands-only CPR on children and infants for lay people who don't have access to a barrier device. Just to kind of bring forward the rule of thumb that I've had for a number of years that I think a lot of us have is we count on our hand the number of people that we would do mouth-to-mouth on. Mine probably gets a little bit bigger. I have 9 grandchildren, my children and stuff. So your scope of where you would do mouth-to-mouth on someone gets a little bit bigger when you look at your immediate family. So when we kind of take that into perspective of that, we can talk somebody into mouth-to-mouth. So when we look at getting respirations to a child that's out there, you can do your hands-only chest compressions and talk a parent, an older sibling or someone else, talk them through how to give mouth-to-mouth resuscitation and work with them. It's working with folks and making them a part of the code, I guess, if you will, and letting them know that they're doing everything that they can as well. That's kind of my 2 cents on that.
Great. Thanks a lot. Yeah, for a really broad topic, I think we had some good conversation there. So, what's that?
I wanted to touch on 2 points. And so the first point is going to be a little bit more superficial, which is about the exam. So, there was some discussion of, calling your hospital and giving an exam, and what is it that we want to hear? So I just wanted to kind of touch on that a little bit. So when I think about a cardiac arrest, what I want to hear is perfusion. I don't need anything more than, are there extremities? Do they have good cap refill? So think about just pressing down on a finger or toe and seeing, hey, does the blood goes back quickly or does it take a while? So that's a great exam. Can you feel a pulse in the center of the body? So the femoral is usually an easy place to try to feel for a pulse. If you can't feel a pulse in the femoral, you're in a bad place. And so when I think about cardiac, I think about, a quick perfusion check, a quick pulse check. One of my attendings used to, in the cardiac ICU, literally used to walk around and just touch all his patients' toes. And one time I asked, I was like, what are you doing? He's like, well, if the toe is warm, you get blood there. If I squeeze down and the blood comes back, I have good pulsatile perfusion and I have good overall perfusion because it's warm. And that's how he kind of did. And it's the farthest part from the heart. So if you could get blood there and it looks great, then the patient is doing well. So that's one thing I'll say about the exam. And the second thing I'll say about the exam is something that I think has been helpful for my residents. And what I say to them is that the pediatric body protects two things very, very well, and it will sacrifice everything else. So it'll sacrifice gut, it'll sacrifice arms, limbs, sacrifice kidneys, liver. The two things that the pediatric heart protects is itself, the heart, and then the brain. So what I would tell you about impending arrest is if the kiddo looks horrible but hates you, screams, kicks, you come at them with a needle, they don't like you, and they look otherwise horrible, they're still okay because they're able to get enough oxygen in, get the oxygen to their brain, recognize their environment, respond to their environment, and hit you. So all those are good things. If a kiddo is non-caring that you're coming at them, that kiddo is now lost one of the last two organs they want to protect. And once they lose their neurostatus, the next thing they're going to lose is cardiac. So I want to talk about exams in that regard. Like, think about cap refill. That's a big thing for us. There's nuances to a lot of the exam, but I would say cap refill pulses and are they fighting you are kind of my big thing. So that's a broad one. The second thing is a little bit way more nuanced. And I don't know if this is necessarily right for everybody in this group, but maybe for some people in this group. Oxygen is good in kids without congenital hearts. If you don't have a congenital heart history, put all the oxygen you want on a patient. Bag oxygen in, put nasal cannula in. There are limited limited cases where a congenital heart, if it sees too much oxygen, will actually cause a cardiac arrest. The nuance of that becomes a very long lecture, but I want to say that there are times when oxygen is not the right answer, and you will always know when that happens because there will be a parent who flips out when you give oxygen, because any parent with a child of congenital heart that is a single ventricle knows that if their child gets too much oxygen, there's a good chance that they'll arrest. So what I would encourage you to do is, if you walk into an environment where there's a congenital heart, their family is going to be your best advocate. And then following that is to call somebody who understands that anomaly really well, whether it's Sioux Falls or their cardiologist or their primary or somebody, because there's a lot of nuance to congenital hearts that sometimes doing the right things could end up being the wrong things.
Great. A question that I got that was not on the topic list is kind of related. Are we seeing any LVADs in children?
LVADs are in hospital. Bigger kids sometimes will go home with LVADs. I have not honestly seen any in the state. So I trained in Wisconsin, and older teenagers we treat like adults and send them home. Kids do have assist devices. They do go home with them. I would be very surprised if they get to go to a rural location without immediate cardiac support close by. So I could see those kids, having to move to a larger location. But LVAD's probably in older kids.
Great. Thank you.
Kyle, can I weigh in on one more thing here?
Absolutely.
One of the things that for you folks, when we look at cardiac arrest, either a child or adult, is getting your equipment out. practice your codes. Know your device, that everyone knows their device. So if you have a LifePak 15 and it's set in the AED mode, if you have an AED as law enforcement, know your device, how to put your pads on, and be very, very comfortable with that. The other thing is your CPR, know your CPR, get your CPR and good chest compressions. The Lucas device, for those, I'm going to say that some of the gals that are a little bit smaller, work either as a team and be very prepared on how you're going to use your Lucas device. If you have the opportunity to use a Lucas device on a larger pediatric patient, it should go on very, very smoothly, and be prepared for that. It truly, honestly is. It's all about preparedness. And the more that you prepare, the slicker these codes are going to go and the less stress that they're going to be on you. There's great scenarios out there. We have scenario books in our agency as well. Dr. Benson brought something up earlier about children with special health care needs, being aware of the children in your community that maybe have congenital anomalies and other special health care needs. We're working on a group to get some information out that we can push out through our pediatric champions. Again, be patient with us, join our group and see how we can move that forward as well. But it's all about getting your equipment out, getting your hands on it, and practice doesn't make perfect, but it does make permanent. So when you know how to put those pads on, you can put those pads on at 2 o'clock in the morning, or you can put them on at 8 o'clock in the morning. You can put that Lucas device on. If that Lucas device fails in between, and as it fails, that you can change batteries very, very quickly, or recognize that a Lucas device will fail completely and that you don't fight it, that you just basically take it off and you continue hands only CPR, or hands use CPR. So use hand driven CPR, and then your bag valve mask or whatever means that you're using to get your airway. Don't forget about a lot of our BLS services have airways that we're using. The King Airway. We have a lot of BLS services that now are going to the, oh, help me out with the new one.
iGels.
iGel. A lot of them are using the iGels. Use your iGels. Be familiar with that. Practice those things. Again, it's a lot about it. It's practice. Accountability, folks.
Great. Thanks a lot. Michaela, we have one more topic, right?
Yes, sorry. Our final topic then is child abuse awareness.
I think we're going to loop in trauma with this one as well. And let's make it broad, but then break it down. So we're going to talk trauma. And then if we can kind of talk some specific traumas, motor vehicle collisions, things like that, where we have our children who might be in, in seats and so on. How would you guys like us to be, treating those patients? Sometimes, to be perfectly honest, in the EMS world, is if they're in a seat and they're acting fine, we might triage them as a green or something. And I guess just maybe touch on that, and then maybe we'll just break this into two. We'll talk a little bit trauma, and then we'll go into the child abuse side, and recognition and things like that. So let's start with trauma, and kind of gear it towards a motor vehicle collision, and how to handle that, and what you guys would like us to do there, and then we'll spin back onto the child abuse side. All right. Who wants to start this one? No takers.
I'll jump in. We pretty well spent all week. So when we look at, I'm going to go back to pediatric safe transport. So if I'm understanding you correctly, Kyle, you're kind of giving us a scenario where you have a child who is in a car seat. They are maybe in a rollover, and the child is acting appropriately. What
Right.
do you do with that child? Is what you're saying?
Yeah.
So,
would it be appropriate to maybe triage them more of a green or yellow, or just because they are maybe a peds patient, do we need to pay extra attention to them? I guess it's maybe kind of where I was going with it.
I think a lot of it depends on the damage to the car, but then we start looking at the damage to the car seat as well. So if we look at the damage to the car seat, but then we go one step further, and obviously we treat our patient. So we're not necessarily treating what the car looks like. We're not necessarily treating what that car seat looks like. We're treating what our patient is acting like. And then we move that one step further. And as we move that one step further, you're preparing for the worst. So I think most of us have had that training where we take a car seat out, we pull that child out of the car seat, we do, spinal immobilization, and we move that child onto maybe a PD board. Again, this is where you practice your skills. You get your child out onto a PD board, and I'm talking a smaller child, or if you have so our kids should stay in a booster, at least a booster seat, until they're about 57 inches tall or 4'9". I think it's 40 pounds somewhere in there as well. But practice those movements, and then moving them to the stretcher, and then being prepared for what you're going to do as far as your trauma assessment, and then treating your trauma and identification and things in that order. I'll leave it at that for right now, and I'll let Dr. Anderson and Dr. Benson weigh in.
Sure, I guess I can go next. Trauma depends on a lot of different factors. A lot of times parents do not have their children in a car seat or a booster seat, and that's where it becomes pretty devastating. We had a scenario recently where there was an infant and there was no C-collars that we had that would fit that infant, and what do you do? And so what we had kind of come up with was you can use a towel and kind of make a log roll around the neck and kind of tape the head, and that car seat actually becomes the cervical spine stabilizer for younger children. Again, like Carola said, it just really depends on the scene and what everybody looks like. It's best if there's prevention of trauma, and that's what we really work hard at in our community. Is we do a lot of work with prevention of things before they happen. We don't have anybody certified in our community for car seats, and we hope that our reference centers like Sanford and Avera and the higher levels of care do go over that when new children are sent home with their parents. We do try to go over that, what the new car seat recommendations are with every well child visit. We do try to have trainings with some of the children, even of different traumas other than motor vehicle accidents, just so that kids kind of can recognize things. But the majority of the time, we try to work on prevention of trauma. We don't have that much trauma in children, but when we do, it's pretty devastating, and you have to kind of take things case by case. We've talked about this in the last lecture too, is that you do have to be prepared, and you do have to kind of recognize your skills. And so practicing your skills on dummies and going through scenarios before they occur, I think, is probably one of the best things that you can do to prepare for pediatric trauma in a rural area.
Great, thank you.
So Kyle, I'll go back to what you were saying of, you take a child out and then the kid looks otherwise okay, should we treat them somewhat differently? And my first response is no, because I don't want you to start looking at a child who looks okay and wanting to worry about when there's an adult in the field who is sicker. So a couple of things that I would add to the conversation. I agree with what Carola, Dr. Anderson has said already on this, is to take a look at the child and trust your instinct, trust your training. And if a child's in the car seat crying up a storm, check for visible injuries. If not, if they're crying, that means they're recognizing that they're unhappy of having been in an accident. They have oxygen to their brain. They're recognizing their environment, and they don't like you. Those are all good things. If you have a child that is unresponsive, even if you don't see injury, I actually be more worried about that, which then ties into the thing that I would encourage everybody being familiar with, which you will be asked a gazillion times by people like me, which is, what is the GCS of the child? So pediatric GCS is a little different from adult GCS. So understanding that, because that's going to be an important distinction for us. Even if you don't see injury, if the child's GCS is low, they may require a different algorithm and a different pathway. Kids with broken bones, kids with abdominal trauma, you guys know what to do. So I wouldn't treat a child differently just because they're a child.
Great, thank you very much. And maybe we'll spin off into the child abuse, recognition, and maybe what is the best way to handle that, which I think can always get muddy. And especially with a lot of our participants tonight probably being from those smaller communities where they maybe know the people that they're going on. And I know there's been times over my 20 years in EMS where, it's been a thought, and you get that, you maybe discuss it with your team, and somebody will just step up. No, absolutely not. That can't be happening in that house. So, if you guys just kind of want to take it from there and.
Oh, I want this one.
Okay.
So this is what I will say. I don't trust anybody, period. So if a child comes in with an injury, I don't trust who they've been around. I don't trust anybody, period, until I'm 100% certain that they're okay. I don't care if they're a teacher, if they're a pillar of the community. If a child comes in with an injury that doesn't feel right, means that the story that they gave is not consistent. And even sometimes, even when it's consistent, I don't trust anybody. So what does that mean? That means I scan kids' head anytime they come in with an uncertain etiology for not acting right, especially babies, because child abuse is like 1, 2, 3 on my differential, often when it comes to trauma in babies. So now that's one thing. So, and this may be horribly pessimistic, and I apologize in advance, but I don't trust anyone. So the number 2 thing I'll say, Kyle, to your point of being in a small community, one, I can't imagine what it's like. I've never been in that environment where I have to roll up on a friend's house with a child that I'm worried about abuse. I wouldn't know how to respond to that. I will tell you, however, that in the times where somebody's in the unit and people have said to me, there's no way that has happened, what I would say to that individual is, it's irrelevant whether or not there's a possibility. I'm a mandatory reporter. And so I would say to the family, I know, hey, look, I know everything is great. This is not going to be that. I'll do everything I say, I want to say that's all nice and good and happy. And I'll follow that with, but I'm still going to have to do the full evaluation because it's my job, it's the law, and it's something that you would want me to do just to make sure that your kids are safe. And if a parent says, I don't want you to do that, I don't care if my kids are safe, then you know your answer.
So Dr. Benson, that was a huge question that we had last night of who becomes mandatory reporters. And when we look at mandatory reporters, we look at EMS professionals, we look at law enforcement, we look at educators, teachers. It did come up last night, CCD instructors. Who do we all have as mandatory reporters that that fall into that category of as a mandatory reporter?
I actually don't know the complete list. I know the list that you just said, but I use that as almost cover for me when I do a complete workup. So it's almost like, hey, look, this is what's required of me. And I know that you would never do this, but we're going to CT and we're going to call child abuse team and we're going to have everybody come talk to you and the cops are going to be here and have a conversation because that's my job. And you would want me to do this just to be safe.
Folks, those folks, we actually redid our communication aids. Every ambulance service should have these on their ambulance. If you will take a look, there is a portion in there that basically states that there is for child abuse and mandatory reporting. Who do you call during the day? You call DSS, you call social services during the day. In the evening, that's when you call your law enforcement and you talk to law enforcement. If you folks have the opportunity, or this winter when you're kind of sitting inside and the snow's flying and you want to do some education, Colorado EMS for Children did a phenomenal job at providing training to identify child abuse. And I put it in the the chat box there on how to identify child abuse. There are 105 slides, folks. And with those 105 slides, by the end of those 105 slides, and they're all real cases, you will be able to identify normal bruising patterns and abnormal patterns that would lead you to believe that it's child abuse. Also, with ours, we kind of include a couple of things with the child abuse, and that's your normal and your abnormal bruising patterns that you have here. And then I'm going to throw in there just a little bit more. I am incredibly passionate about human trafficking. And when I look at human and child sex trafficking, that becomes about mandatory reporting as well. Our HEC coalition, or our Heartland EMS for Children coalition, we're getting ready to attack that again in January. That'll be a 2-part session, but hang tight with us. We're really trying to bring those things, community awareness, community prevention. There's a lot of resources that our office has, but there's a lot of resources that your local community hospital has. When we look at Faulkton is doing amazing things. Sanford Children's, Avera, and I'm not saying, you know, just one particular hospital in general. Our hospital facilities are out there for us. The trauma coordinators, their outreach and their community outreach is absolutely amazing. Reach out to your hospital facilities, reach out to your law enforcement. I got Chris Mislett on online here with me, sending me a note saying, hey, if you need some assistance here, I'm willing to help. I talk, what did he say? I talk cop sense is what he says. So people are willing to help.
And then I want to just add a few things. I appreciate all your resources. I actually have a medical student right now who is at that South Dakota Child Abuse Conference. I think that it's in Sioux Falls right now, but she did a talk and she gave me her talk to kind of share. And I'm just going to share a few highlights, but in regards to EMS, these are the questions that from our standpoint that we would like you to kind of make a note of when you attend to a child that you're a little bit concerned about. So these are some questions. So what are the living conditions of the child? Do they appear to be in an unsafe or unsanitary environment? How does the family relate to the child in the current situation? How does the caregiver interact with the EMS professionals? Are the injuries consistent with the mechanism of injury? And is the story being told change over time? And some of the signs of abuse, it says the most common signs of abuse are the 3 B's: burns, breaks, and bruises. And then of course, bruises in the patterns that Corolla just talked about, and a broken bone and a preambulatory child, so that's a child that cannot walk, is abuse until proven otherwise. Like Dr. Shu said, I do live in a rural area and I don't have a problem, I guess, telling family members or parents that I need to report to Child Protective Services because I am a mandatory reporter, and we call pretty often. If we have concerns, then that takes anything out of our hands. You know, we're covered, the child is covered. Sometimes we feel like maybe CPS doesn't get back in the time frame that we want them to, and if we're really concerned about the child, we do involve the sheriff's department in our local county, and we make sure that that child is going to be safe before we let them go on. If we're very concerned that they're not going to be safe, we do transfer them to a higher level of care so that they can get the appropriate workup and see people that can help the child, and that takes us out of it. You know, we might be friends with the family, but that takes us out of it. Makes us mandatory reporters, but it takes the emotions out of it. So I just wanted to share those things that kind of we're giving from our medical student, and then kind of from a perspective of the rural area.
Dr. Anderson, I really appreciate what you said about reporting locally. And I see that Jenna, one of our transport nurses, also brings that up. So I want to emphasize what Jenna said. You know, it's better to report locally. I've lost numerous hours, days sometimes when they end up in Sioux Falls, reported there, and then it's well, who gets to investigate? Where do we do? And in that time frame, keep in mind, often there are other kids at risk. Often there's evidence being lost. I'll point to a story that I had when I was in training. We actually had a kid come in with a brain injury, and we immediately got the police to go to the house. and they were basically about to like cover up the drywall dent that was where the child's head had hit. And so, there is an importance of time and importance of local reporting to get the ball moving and to protect the other kids in the household if there are other kids.
Very good. Do we have any other questions associated to child abuse or child abuse reporting? I've had a couple of other ones come in, but let's finish up with this topic. Does anybody else have anything? You can either ask it in the chat box or you can unmute and ask it yourself. I think you guys did a very good job covering it, though, from all perspectives, which is phenomenal. All right, Michaela, do we have any other topics? Or I know I added one there, but.
Nope, those are the three kind of main ones we thought about. So
Okay, so then I think we're just going to open it up for general questions. And the first one I'm going to start with, and I think this will be a good one to get perspective from all three of you on, since you all three probably deal with this in a different setting, is any recommendations for trauma in the younger school age football players? Most common injuries you're seeing, things not to do for specific injuries, things to do. I mean, we're getting kids in what, third, fourth grade playing tackle football. So let's just open it up for the general questions. And that's the first one is any recommendation for trauma in school age football players, most common injuries that you're seeing, what to do, what not to do when we see those types of injuries.
I would say always involve somebody that knows the child as a baseline. And I guess I'm not a big fan of football of any age. And I don't let my son be in football, and he's very upset, but he's had concussions from other reasons. We do a lot of sideline training, I guess, with our EMS, because I think most EMS has to go to football games, but I don't believe that you go to any of the younger games. I think that's mainly for high school. I don't know if in larger towns, if there's EMS that does go to those younger games, but you developmentally, Dr. Shu can speak to this a lot more, but developmentally, everything is still developing. The brain's developing, the bones are developing, everything is developing, the muscles, and there can be a lot of overuse patterns. A stinger and a burner in a younger child might not be a stinger and a burner. A head concussion can be incredibly dangerous. I don't know how to answer it other than I don't like it. And we don't go to the younger children's games, and we don't see a lot of it because the parents only bring them in if they're concerned. But if they bring them in because they're concerned, they're the best use. We see what the child's baseline is, and parents are able to give us that information. So.
Yeah, I'm a pediatrician. That's a loaded question. Kids, head injury, football, bad, very bad. I agree with the idea of having somebody who knows them. What I often worry about, to what Dr. Anderson was saying, is that by the time the family brings you their child, it's way worse than just a concussion, or it's a bad concussion. And the thing is, I'm a football fan. I watch NFL, but now in the last several seasons, there is a independent person on the sidelines looking, because it's so easy just to go back in the game. So the younger you are, I would encourage not having doing flag football, not having that tackle component. But having said that, the pediatric brain is really something you want to protect.
I'll weigh in here just a little bit. I think it's community accountability. And with your community accountability, oftentimes we see that we do enjoy watching our children play sports, but it's about the equipment, and that these kids are having appropriate equipment that is sized appropriately for them, that it's equipment that is not a leather football helmet. And I know I'm kind of pushed that just a little bit further than it needs to be, but we need to make sure that our equipment is appropriate for those children, and that they're being taught appropriately, and that the sport is, that it is a sport, and that it's hold your coaches accountable, hold your community accountable with that as well. I'm not going to get into a lot of politics. I'll just kind of back down off of that one.
All right. Well, thank you guys. Do we have any other just general questions or anything that we've talked about tonight? One just popped in. Maybe taking that one a little bit further and talking maybe how to handle the emergency on the field if we are EMS providers on the scene. Some things to look for and how to actually handle it on the field.
Yeah, I'll expect the worst. So if you're worried about head injury, protect the spine, get the child to a provider. Depending on the environment, concussion protocols. The American Academy of Pediatrics has a lot of data out there and a lot of protocols out there of what to do for a child who's had a concussion. So keep in mind all of that. The worst injury, so I don't see a lot of concussions from football coming into the ICU. What I do see is fractures. There's a lot of bad breaks through bad tackling. So things to keep in mind is perfusion of the the bone and the distal space. So looking at pulses, making sure that there's pulses, being concerned about fractures that may disrupt blood supply, stuff like that. And again, getting them to a facility sooner than later, stabilize, and then immediately transport.
Going back to your training, folks, your BLS training, and do you remove a helmet? Do you not remove a helmet? If you're removing the helmet, you're going to remove the pads. If you're going to remove and how to appropriately provide C-spine immobilization while somebody else is bringing and pulling that helmet off. Do you have the capability of taking that face mask off with the equipment you have? That everyone is familiar with removing that face equipment. Suction, having your suction available, especially when we're looking at the possibility of a child who has a concussion and being prepared for emesis or vomiting, either applies to that. Do we do a log roll? Do you have enough folks on board to do a log roll, or is it just going to be suction if there's copious amounts of vomiting that's going on with that? Go back to your basics, folks, and practice. Again, it's get your hands on and practicing those skills so that when you do need to use them, that you're proficient at it.
Yeah, and we've talked about this in other questions too, but also use your gut. If you have a child that looks at you and they say, I don't feel well, I don't know what's going on, I don't feel well, they need to be seen in a emergency room. They can't just be evaluated on the sideline. They need to be evaluated further. There's a lot of things that you can learn about how to do a sideline evaluation, and we kind of go through that, whether you do like heel to shin testing and balance, and you have them say, where are we in the game, and you try to ask them some orientation questions, to see if they can go back in and return to play. But if you have a kid that gets tackled and they get hit anywhere for any reason, and the kid's not comfortable, but the coach and the parent, they're all gung-ho and they really want their child to keep playing, and you have to make the call on behalf of the child.
Very good. Another spin on that question. Is there an occasion when a helmet should not be removed?
I don't know the answer to that one, I guess.
Yeah, I don't know the answer to that one either.
I guess what I've always learned over the years doing, sideline stuff from junior high all the way up to NCAA Division II over my career is, if the airway is not compromised and that helmet is helping us to maintain C-spine, that there's really no reason to move it. Now, if that airway is compromised and there's something that we need to do, with that neck area, that facial area, then we would remove it. But from my training that I've gotten over the years is if our airway is not compromised, then that helmet and those shoulder pads are actually helping us. There's no reason to remove them at that given time until we get into a more controlled environment and they can be evaluated by a physician in an ER.
My training is basically the same as what yours is, Kyle. If you remove one, you have to remove the other. Removing that face mask and being comfortable that you have the tools to remove that face mask and you're proficient.
And just spinning off on a question that came in is there some place to find this? If you go into the EMT curriculum right now, into the it's one of the topics, I forget exactly what it is they do a very good breakdown of how to remove football, motorcycle, all those types of helmets. So I think if you just go into the EMT curriculum, you'd be able to find that information. All right, any other questions? Anybody? Well, I think this will bring us to the end of our lecture, or our kind of our roundtable tonight. I do have a couple of other things to talk to you guys about. First off, I know we can't give them a hand because it really doesn't work that way when you're virtually, but a big, huge thank you to all three of our panelists tonight. This worked really, really good. I think we had a very wide range of perspective and very great. So one thing that we're going to talk about, Corolla, do you want to answer that question that came in on the child abuse side of it? One thing that I want to talk about quick is next month. We are not meeting at the end of October. So we are not meeting the Thursday, whatever it is, the 28th. We will not be meeting that day. The reason for that is we will be at the South Dakota EMS conference in Pierre. So that is where we're going to be. So we are going to do our October meeting. Help me on this, Michaela. November,
sorry. I don't have my
November
calendar
4th?
for it. Yes, I believe so.
November 4th. And I do believe we have a topic. We're going to talk about the things that we see in hunting accidents and some trauma like that. So that's what we're going to be talking about in November, because it's going to be 'tis the season for that stuff. So we are going to be talking about that in November. And then our November meeting will be actually in December, because we run into Thanksgiving. So it's crazy to be talking about that stuff already, but we're there. And so we're adjusting our last Thursdays for the next 2 months, kind of the first Thursday. So November be the first Thursday and December will be the first Thursday. So that's kind of where we're going to be at tonight. There's also going to be a survey at the end of this. So anybody that's on, make sure you jump back and you do the survey and scroll down. I usually have problems with scrolling down, and then I tell Michaela it's not working. You just have to scroll down. It's there. The next thing I'm going to talk about is, I know we have a lot of new people on that maybe haven't been on these before. And the way you get credit for these is you go on to your South Dakota EMS portal and you sign into that and you find this class that's in there. I think we're called Pediatric Roundtable is what it's called. And you register for that class. Now, if you've never done that before and you have no idea what I'm talking about, you can send me either an email or put it in the chat box what your name is or your EMT number, so I can give you credit for this class. So I think earlier today we had like 34 people that were signed up, and we had 65 on tonight. So if you have not signed up on the South Dakota EMS website, it's a different website than where you got your link through and that you registered through to get your link. So it's a 2-part deal is what it has to be. There's no way that we can bring them together. I wish we could, but we can't. So you need to register for the class, which is where you get your Zoom link. And then you need to register on the South Dakota EMS portal to get credit for the class. And again, if you have not done that or you need help doing that, you can put your name, how it appears on your EMT card, because I've ran into those issues where different names and I can't find you. So put it on your either in the chat box or send me an email, and I will be sure to get you credit for that. Next thing is, again, going to stress the South Dakota EMS conference coming up at the end of October. Some great presentations. If you have not signed up, please do so. If you can't make it to Pier, do the virtual side of it. I think there's like 18 hours, 16, 18 hours of credit that you can get there. So make sure you're signing up for that so you can get that credit. And Michaela, anything I missed?
Nope. I guess one thing is AHEC will have a booth at the state conference, and we have little cards, and if you're interested, and we can send them out as well, that just have the topics of the webinars and the month and the date on them. So we can send those out, or come see us at the EMS conference.
Yes, the cards look great. They'll tell you what we're talking about each month. And I think that this is going great. This is kind of our, I don't know, 5th or 6th month of really getting this going, but I think we've been doing this kind of for about a year already. So tell your friends, tell your coworkers, tell your EMTs, your neighboring communities. And we're working on potentially being able to get some nursing continuing education hours, some physical therapists, occupational therapists type continuing education hours. We're looking into that, and it's going to take a meeting with South Dakota Board of Osteopathic folks. So wish me luck, but we're going to try to get that stuff accomplished as well. So do our presenters have anything that you guys want to leave us with tonight?
Kyle, I would like to thank you and your staff for these presentations that you've been doing over the last several months, especially and particularly pediatrics, and bringing those pediatric cases forward, or those pediatric issues forward. We all know about 10% of our cases are pediatrics. One of the things that you folks need to keep in mind, we're running about 8,000 calls a year, pediatrics 0 to 18. Somebody's running them. Sioux Falls is probably running the majority of them. Rapid City is followed up right behind, and then it's spread out amongst the rest of you. And in my research that I've done, we look at flight, and flight is probably running 600 to maybe 1,000 of those. Hi, Robin. And flights running about 600 to 1,000 of those flights or of those calls. So we do have pediatric calls out there, folks, and I really thank you so much for bringing this forward. And Dr. Benson, and very good to see you as always. And Dr. Anderson, it has been such a pleasure working with you over the last several months. And say hello to Lindsay for me.
Yep. And I really appreciate each and every one of you that participates in South Dakota EMS. We really struggle to find people on the ground to help us, and we need you guys, and I really appreciate you guys attending these, and I really appreciate you guys keeping going with your education and helping us out.
Everything Dr. Anderson says. I can't do my job without you all doing your job. The kids won't make it to me without you guys doing the right things, and I appreciate you being out there and taking care of the community the way that you do. Thank you.
All right, thank you all very much. I just want to leave you with one thing is I appreciate, Corolla, your comments on us doing this. We could not do this without South Dakota Northeast, South Dakota AHEC. They have been a fantastic partner in this, and they have been able to get the South Dakota Community Foundation involved to fund some of this stuff. So when you do stop at the booth at the EMS conference, hopefully all of you are going to be there. Thank Michaela. Thanks, Andy. Thank the folks that are there, because they have really stepped up to the plate to help us get this education out to you guys. And I know this started as COVID calls a year and a half ago, and it's evolved into what we have today, where we are reaching 60 some people from all corners of South Dakota and beyond. I think last month we had people in 3 or 4 states, and pretty much people from all corners of South Dakota. So this is, I think, is a great supplemental tool, and we appreciate Northeast South Dakota AHEC coming on board with us and kind of making a vision that some of us have had for a number of years a reality with what they can do for us. So thank them. They are Michaela is the worker bee when it comes to this stuff. So be sure and thank them when you see them, because they do a fantastic job. Michaela, anything else?
No, thank you, Kyle. No, I think that's all we have.
All right. Well, you can drop chats in. I see there's a few with some issues. We'll get you all taken care of tomorrow, probably. And email me as well. And if you do want to watch this, or you have people that want to watch this and then let me know within 30 days and I can still get you credit for it. So it's got to be within 30 days. So let me know, email me, tell me who watched it. Maybe have a little test for them. Make sure they did it. No, we will. We take your word for it. So if you have people that didn't make it tonight, they can sure watch it within 30 days and get credit for it.
Kyle, can I ask real quick, like where they're watching these videos, the recorded videos?
Michaela?
We have it on the AHEC website as well as YouTube, and then we'll also have Zoom as well. So there's different.
So you do have, okay, so you do have a YouTube channel then?
Yes. Yep.
Fantastic. If you would share that with folks, I think that'd be really great.
Sounds good. Yeah.
All right. Anybody else? Last call. Thanks again to our wonderful speakers. You guys did a great job. Thanks for bearing with us on a virtual roundtable. First one I've done. Can mark that off the list, right? We will probably do some more of these over the course of our talks. It brings a lot of different perspectives into one session. So hour and a half of continuing ed tonight. Let me know if you need ALS hours. Let me know if you need help getting signed up, and hopefully see you guys all at the end of the month at the EMS conference. Have a good night.